Bismillahirrahmanirrahim. My name is Dr. Imran, and today presentation is about TRBT, diagnosis, staging, and treatment. Our objectives are diagnosing bladder cancer, TURBT, surgical technique of TURBT, procedure, instruments, challenges, and complication. Non-muscle invasive bladder cancer is the term most commonly applied to the malignant urothelial tumor that have not invaded the detrusor muscle. Most common malignancy of this is the most common malignancy of urinary tract. Majority of neoplasm are epithelial, and among them more than 90% are urothelial tumors. 70% of all bladder cancer are non-muscle invasive. Tobacco smoking is the most common recognized risk factor. Occupational exposure mainly occur in industrial plants worker, which process paint, dye, metal, and petroleum products. Non-muscle invasive bladder cancer is more common in men. Risk of recurrence of the non-muscle invasive bladder cancer is 17 to 70%. And progression to muscle invasive bladder cancer. Factors associated with recurrence include previous recurrence, number of tumor, and the tumor size. Painless hematuria is either visible or non-visible is the most common presenting symptom. Other irritative voiding symptom in the absence of urinary tract is urinary tract infection is also associated with the carcinoma in situ. This is the relevant anatomy of bladder is important for the staging of the bladder cancer. From outer to inside, inner side, it is perivesical pit, serosa, muscularis mucosa, lamina propria, and urothelium. Tumor in situ is a plate tumor which is confined to the urothelium of the bladder. TA is when it crosses the urothelium to the lamina propria, and T1 is when it crosses lamina propria to muscle. T2 is also when it crosses to the muscle, and T3 it is cross muscle and confined to a bladder wall.
T1 is not to the muscle, Dr. Imran. T1 is to the lamina propria itself, and when it reaches to the muscular mucosa, then it is muscular layer. Sorry, then it is T2. अच्छा, दूसरा ये बताएं कि हाउ वुड यू कैटेगराइज डॉक्टर जकाउल्ला, डॉक्टर समी, डॉक्टर तनवीर, ब्लैडर ट्यूमर किस तरह से कैटेगराइज करेंगे आप लोग, बेनाइन और मैलिग्नेंट? अगर हम उनको कैटेगराइज करें तो बेनाइन और मैलिग्नेंट है ना। मैलिग्नेंट में फिर इस तरह से जो है प्राइमरी एंड सेकेंडरी, ठीक। प्राइमरी फिर दो में है, नॉन मसल इन्वेसिव एंड मसल इन्वेसिव। सेकेंडरी from the like secondary adenocarcinoma from the prostate or gut, और जो है फीमेल में यूट्रस से ओवरीज से, that would be secondary, ठीक है। उसके बाद जो उन्होंने बोला कि ट्रांजिशनल कौन सी एपिथेलियम इसमें होती है, वेरिएशन में इनके कौन से आ सकते हैं दूसरे, मतलब टीसीसी इज मोस्ट कॉमन 90%, ठीक है। वेरिएशन में स्क्वैमस सेल कार्सिनोमा और जो अदर हिस्टोपैथोलॉजिकल वेरिएंट्स है, एडिनोकार्सिनोमा, स्क्वैमस किस में ज़्यादातर मिलता है, अप टू 90% ट्रांजिशनल सेल है, 1 to 7% स्क्वैमस है, और 1 to 2% एडिनो, ठीक है। और कौन से इसमें स्क्वैमस सेल कार्सिनोमा में ज़्यादा मिल सकते हैं प्रेजेंटेशन में? हाँ, ठीक है। और यस यस,
catheterized, patient
Yes.
is catheterized.
गुड, ठीक है। अच्छा, उसके बाद उन्होंने प्रेजेंटेशन में बात की, एज कौन सी आप एज में आपको मिलते हैं मोस्ट कॉमनली, बोले?
7th decade of the life, 63 to 70 years.
ठीक है, अर्ली एज में भी मिल सकते हैं। अर्ली प्रेजेंटेशंस में कोई हिस्टोलॉजिकल वेरिएंट जो कॉमनली हो, स्क्वैमस वेरिएशन जो हिस्टोपैथोलॉजिकल है, वो अर्ली एज प्रेजेंटेशंस में जो होते हैं,
T4 when it crosses the bladder wall to the adjacent organ of the pelvic. TURBT. TURBT is a complete transurethral resection of all visible tumor with adequate depth to include the muscularis propria. The quality of TURBT is of primary importance. TURBT is diagnostic as well as therapeutic procedure. Goal of TURBT and TA and T1 bladder cancer is to establish accurate pathological diagnosis, staging, and completely remove all visible tumors. TURBT, Edwin Weir first reported endoscopic treatment of bladder cancer using electrosurgery in 1910, and 1962 Johns and Sweeney first described endoscopic removal of bladder tumor using a resectoscope. Goal of TURBT, a successful TURBT include identifying the factor required to assign the disease risk, like number of tumor, size, number of tumor, location, size, architecture, concern of for the presence of CIS recurrence versus primary tumor. For the clinical staging, we do to be done by manual examination under anesthesia, assignment of clinical tumor stage, and adequacy of resection will be done by visually complete resection, visualization of muscle at the resection base, and visualization of tumor in the distal ureter. The presence of complication to be done by assessment for perforation. Before TURBT, we should take history from the patient about hematuria and LUTs. In physical examination, patient may present with the patient may look pale and in advanced stage which involve the bilateral use. Patient can come in uremic condition. We should take history about smoking history, medication like anticoagulation medication aspirin, which can cause hematuria, like symptom or hematuria. We should take about history about prior surgery and prior urothelial cancer and the grade, stage, and treatment. Cardiac and pulmonary status, imaging of genitourinary tract, outpatient cystoscopy performed, cytology if obtained, urine analysis, and consent the patient with description of planned procedure, possible complication, and post-operative expectations such as catheterization and intravesical therapy. And should we discuss preoperative medical clearance depending on local requirement and patient comorbidity.
चलिए देखें इसमें आउट पेशेंट स्कोपी सिस्टोस्कोपिक इंफॉर्मेशन दैट इज a great initiative we are going to go for inshallah soon. Sir, there was a question about it, Dr. इन्होंने पूछा था मेरे से कि इसके लिए आपको कल्चर्स किस तरह से आप देखेंगे कि मतलब हम तो उसमें द थिंग आई सेड कि फर्स्ट जो अपीयरेंस होगी स्कोपिक हेमेचुरिया के प्रेजेंटेशन के साथ है अगर वी हैव यूरिन डीआर लिपस्टिक उसमें अगर नाइट्राइट्स हैं दैट अंडर एंटीबायोटिक कवर कैन बी डन.
लेकिन दो उसमें जो है पॉपुलेशंस हैं वन इज विद कैथेटर एंड वन इज विदाउट कैथेटर. So if the person is with catheter, then that person should have a proper dipstick test. One that is without a catheter should be done with only one single shot of gentamicin if the renal function is normal. So this is how the whole thing will go on, and these are only for new cases. जिसको आज आपने देखा आपने हिस्ट्री ली उसको हेमेचुरिया था सस्पिशन था उसने कोई इमेजिंग नहीं कराई अभी तक और जो फर्स्ट रिपोर्ट है वो आपका ये फ्लेक्सिबल देगा. नाउ दिस इज समथिंग व्हिच इज रिटन इन द गाइडलाइंस और ये अभी तक हम कर नहीं पा रहे थे. इसमें हमें बहुत दिन लग गए बहुत साल लग गए. अब उसको एकदम से ना वो प्रेशराइज करना कि नहीं इसके अंदर आप चेक सिस्टोस्कोपी भी कर लें इसके अंदर फला भी कर लें ये भी कर लें हम सब कर लेंगे लेकिन लेट्स स्टार्ट फ्रॉम समवेयर which was actually missing as per guidelines. So you always start with some kind of
Beginning.
policy. ये policy इस तरह चलेगी.
Along with that, sir, हमारी semi-rigid पे फिर भी we have good orientation about the viewing it. Flexi, obviously, it would take time. Then it can go for like check specific later on.
बिल्कुल आप अगर आप रोजाना की हमारी वो देखें ना, 2 OPDs होती हैं, हर OPD के अंदर नॉर्मली जो न्यू केसेस होते हैं, इट्स नॉट मोर देन मे बी 8 or 10 न्यू केसेस. Out of those 10, you can always start with all of them or maybe 50% of them. और ये कुछ पहले सीनियर आदमी ही करेगा, because it needs only 5 minutes. So it's a 5-minute examination done, office procedure, no anesthesia required, just analgesia. But obviously उसकी aseptic technique जो है ना बहुत ज़रूरी है. Instrument has to be cleaned properly, dipped into side X. तो वो सारा procedure जो है ना वो होना होगा. So that is the reason why it is done in OR1. तो वो पूरा एक सर्किट जो है ना वो हमने क्रिएट कर लिया.
अच्छा सर, हमें जो फुल ब्लैडर के साथ ग्रोथ दिख रही है, लेट्स से उस ही वुड आल्सो गो थ्रू दिस चेक्सकोपी.
फुल ग्रोथ के साथ आपको कहाँ दिख रहा है?
ब्लैडर, फुल ब्लैडर के साथ अगर हमें ग्रोथ सस्पेक्ट,
अल्ट्रासाउंड पे ना.
जी जी.
तो योर अल्ट्रासाउंड विल बिकम नेक्स्ट.
ओके.
राइट. सो देखें हम हर चीज को इस तरह चला रहे होते हैं ना कि एवरीबडी देयर इज एन SIUT. देयर इज नो SIUT एनीवेयर इन द वर्ल्ड. आपको हर जगह जो है ना वो चीज रेडियोलॉजी में मिलती है. अल्ट्रासाउंड इज नॉट देयर इन द ऑफिस ऑफ अ यूरोलॉजिस्ट. अल्ट्रासाउंड इज देयर इन द ऑफिस और रेडियोलॉजी डिपार्टमेंट. तो वो उसके लिए टाइम होता है, उसके लिए जो है ना वो टाइम लिया जाता है. तो यहाँ जो पहली चीज जो की जाती है ना वो फ्लेक्सी है. तो फ्लेक्सी से स्टार्ट करेंगे और वहाँ आपको ना थोड़ा सा फिल्टर हो जाएगा कौन से पेशेंट ऐसे हैं जिनको आगे प्रोग्रेस करना है, कौन से ऐसे हैं जिनको प्रोग्रेस नहीं करना. अब हम कर क्या रहे हैं कि हम पहले जो है ना सारी चीज़ें कर लेते हैं, सिस्टोस्कोपी भी कर लेते हैं, बायोप्सी भी कर लेते हैं, CT स्कैन वाज नॉट डन. So your clinical staging is actually done later and your pathological staging is done earlier, and this should be reversed. दुनिया भर में clinical staging is done earlier, pathological staging is done later.
अपर ट्रैक भी साथ में देखें,
है ना. So वो हमारे यहाँ की कहानी अलग थी ना. अब हम उस कहानी को सीधा कर रहे हैं.
These are the instruments which are used in TURBT. From the medial to the lateral, we will start. These are the endoscope. First is
अच्छा, वैसे भी अगर कोई केस आपके पास रेफरल केस है और आप कहीं और से अल्ट्रासाउंड के साथ आ गया है तो आपके जहन में होता है कि मे बी इट्स अ फिक्स्ड काइंड ऑफ क्लॉट, है ना. इट्स नॉट मूवेबल. सो टू डिफरेंशिएट बिटवीन अ क्लॉट एंड अ ग्रोथ, still this is a very simple test and a simple examination. So there is no harm doing it, and under local anesthesia there is no point in having a detailed kind of.
These are the telescope which are used in the TURBT. The first one is 30 degree and 0 degree and 70 degree. Then is the telescopic sheet, visual obturator, and these are the bougies which can be used for urethral dilatation. And this is the Big B ureteric catheter guidewire introducer. This is the, and cold knife, colon knife, grasper, forceps, bipolar. These are the.
डॉक्टर हमजा कौन सी स्कोप यूज करेंगे कोल्ड का बायोप्सी के लिए?
22 FR या 40 FR.
गुड. अच्छा, कोलिन्स नाइफ?
कोलिन्स नाइफ के लिए भी सर हम 21 और 24.
रेजेक्टोस्कोप, हाँ रेजेक्टोस्कोप वाला शीट यूज होती है 26 फ्रेंच. ठीक है. अच्छा, इसके बाद ये स्कोप ये क्या नाम है, टेलीस्कोप क्या कहेंगे इसको, लेंस हमारे पास जो है 3 वो हैं, 0 डिग्री, 30 एंड 70. ठीक है. और TURBT कौन से उससे लेंस यूज करते हैं? गुड. क्यों? 0 से क्या करेंगे हमजा?
साइज ऑफ द ट्यूमर, लोकेशन ऑफ द ट्यूमर,
ओवरऑल स्कोप ही हम 0 यूज करेंगे. 30 क्यों यूज करें?
then resection by the 30 and for the interior wall and for the use 70.
नहीं, जीरो से आप लोकेशन ऑफ द ट्यूमर, साइज ऑफ द ट्यूमर,
Sir,
एवरीथिंग क्यों दे, कैसे देख सकते हैं?
ब्लैडर में
Bladder में?
यूरिथ्रा ब्लैडर में पोज है।
नहीं, आप कहाँ देख रहे हैं ग्रोथ? जीरो से any other instrument, because the reason that it sort of lifts and cut, and it can engage the individual detrusor fibers. So वो जो है बहुत important है.
सर पेपलरी में या सॉलिड ग्रोथ में भी
डिपेंड करता है कि उसकी जो डायमेंशन है एट द बेस इज नॉट मोर देन 1
वाइड
centimeter
नाउ
wide now. Otherwise, you will be losing sight of what's behind. So your instrument is actually working in shadow if you work posteriorly, because the shadow is created by the growth. तो वो जरा मुश्किल हो जाता है. आप इमेजिनेशन पे चल रहे होते हैं कि यहाँ ग्रोथ थी, होगी, वहीं पे परफोरेशन हो जाती है.
करंट डिस्पर्स
हाँ.
Of en bloc resection of the bladder tumor in a old patient present on the left bladder wall, 75 years, presented with hematuria. Even though it is reported as 2 centimeter, it appeared little bigger on cystoscopic view. Why I'm mentioning old patient is definitive comment on the muscle, both lamina propria as well as muscularis propria is very important. It is a solid tumor. Cystoscopy, rest of the prostate, the bladder, prostatic urethra, everything is normal. It is classically situated 2 centimeter lateral to the ureteric orifice. Thulium fiber laser we routinely use with 110. The important advantage, as we mentioned in the previous videos, is that you can go as much deep almost to the level of the perforation. You can maintain the plane at the level of the perforation or just below the perforation. Here in the deepest part I have perforated the bladder. There is one more small backside growth was there. I am including both of them in the specimen. When you see here, I am going very deep, and when I am cutting, the muscle fibers are clearly seen. The only problem is en bloc is opposite side of the tumor mucosa. We should see and mark it. Otherwise, you will be cutting and going deeper. You can appreciate the speed of the cutting. See, this is actually the perforation. Very vesical fat is seen, and it is a very controlled perforation of few millimeter depth outside. So it is a massive radical en bloc resection, actually speaking. This patient may not be fit for the radical cystectomy because he has multiple comorbid illnesses. This I have done under spinal anesthesia without any risk of the perforation. The only problem with this is we cannot give mitomycin or any intravesical agent. But if I get good comment on the muscle, patient can opt for radiotherapy without going for one more relook TURBT. That is the aim of the future. And less than 3 centimeter, this may become the gold standard, because you can definitely comment in this case, muscle has come, lamina propria has come. Ultimately, lamina propria invasion was there in this case, and muscle was not invaded. This is high grade tumor. The options are there. Now, how to remove this? See what I am saying here. You remove only the front spot. Easily you can remove by encasing that. Don't touch the base at all. Don't touch the base. This you can do before also, but it will bleed and you will coagulate. Now it is after the en bloc resection, it is dead. Don't go into the base. This needs little technical skill. Engage the loop into the lumen, and see here, chunk which is present, major chunk, I will hold with the loop and carefully I will take it out. Entire base has come nicely. 100% you can comment on the place where you have cut with laser. Now I am coagulating. Very good coagulation thulium fiber laser causes. All around you can coagulate. Re-inspect the bladder. The only thing is it takes 10 minutes extra time than TURBT. Absolutely zero bleeding. Entire bladder area, as a matter of fact, deepest area is perforated. All the prostatic urethra and the rest of the bladder inspected. This patient by this surgery will avoid relook TURBT. He can choose radiotherapy. he can choose radical cystectomy directly without TURBT
आगे चलो।
or any other option possible, including intravesical.
Monopolar and bipolar resection. Compared to monopolar resection, bipolar resection has been introduced to reduce the risk of complication, like, for example, bladder perforation due to obturator nerve stimulation, and to produce a better specimen. Bipolar resection has become increasingly popular and is easy to learn. The advantage of bipolar resection and use of normal saline rather than water or glycine is less cautery artifact and lower the chance of obturator nerve stimulation. A meta-analysis includes six randomized controlled trial found bipolar TURBT to be associated with shorter operative time, less blood loss, shorter catheterization time, decreased obturator nerve stimulation, and decreased incidence of bladder perforation compared with traditional monopolar procedure. In addition, a decreased rate of tumor recurrence was noted at 2 years. Second, re-TURBT is done for the detection of residual disease and tumor upstaging. The significant risk of residual tumor after initial TURBT of TA and T1 is done for the residual cancer. Residual cancer has the potential to worsen oncological outcome. And to be done for the incomplete initial TURBT, T1 disease with absent muscularis layer in the histopathology. Second TURBT provide more tissue for the diagnosis and reduce the likelihood under staging of T1 disease. This is the checklist for the TURBT. First, cystoscopy to be done.
Sir, next.
Urethra, prostate to be urethral orifices, diverticula to be seen. Tumor location, number, size, and appearance. White light or neuroband imaging. Urine for cytology is taken. A resection technique, depth and completeness of the resection, visualization of detrusor muscle in the tumor base, prostatic urethra biopsy required, and additional procedure that is retrograde contrast study. Estimated blood loss, complication if any, and intravesical therapy if given are planned in recovery setting. This is our cystoscopy report, which are we using in our setting.
Sure. Next week, on this day, that is Thursday, we'll be having a meeting of all the list in charges on this very topic of online application of certain proforma. So the TURBT, TURP, cystolectomy, PCNL, UCL. So there are, I think, 10 or 11 different kind of proformas available online. So EHR has already made them. First, we start with a shorter meeting of list in charges, and then we'll go towards the bigger meeting of all of the faculty. So next Thursday से हम ये करेंगे, so that next year we should go in with paperless kind of proforma formation. So there will be no two things. ऐसा नहीं होगा कि उसकी आप print निकालें और file में लगाएं. There will be no file at all. Everything would be on screen. ठीक है?
जी सर।
तो ये वाला खत्म हो जाएगा और इसकी कोई जरूरत नहीं रहेगी. इससे बेहतर आ जाएगा. बस ये बनाया मैं नहीं था बस. सही.
Challenges and TURBT. Anterior wall resection, TURBT in diverticuli are growth and the UOs. Tumor within bladder diverticula are also considered to be difficult to obtain complete clearance due to suboptimal access and resection, in particular if diverticular neck is narrow and lack of muscularis propria layer. This would pose an increased risk of perforation and the inherent limitation in the assessment of the depth of the tumor invasion. In view of this, small low-grade tumor can be carefully resected. Diverticulectomy, partial or radical cystectomy is considered to deal with large high-grade tumor in the diverticulum. Anterior wall tumor and tumor at the dome. These tumor with large bladder can be difficult to reach. For this, minimal bladder filling combined with manual compression of the lower abdomen wall to bring the tumor toward the resectoscope facilitate entirely of most bladders. Digital manipulation through the rectum or vagina can occasionally facilitate the resection. Urethral orifices. Care must be taken during the resection near the urethral orifices to prevent obstruction from scarring after pulgration. Pure cutting current causes minimal scarring and may be safely performed, including resection of the orifice if necessary. Resection of the intramural ureter can sometimes lead to complete eradication of the tumor but risk reflux of malignant cells. The clinical implications of this are unclear. Complications of the TURBT include iatrogenic injury like bladder perforation, injury to the urethra, ureter, irritative symptom, and TUR syndrome. Minor bleeding and irritative symptom are more side effect in the immediate post-operative period. Major complication like uncontrolled hematuria, clinical bladder perforation, which occur in 1 to 6.7% of cases. Perforation tend to occur in elderly patients with large posterior wall tumor and cases with multiple courses of intravesical therapy. Incidence of perforation can be reduced by attention to the technical detail, avoiding or distension of the bladder, and using anesthetic paralysis during the resection of lateral wall lesion to lessen obturator reflex response. Majority of perforation are extraperitoneal, however, intraperitoneal rupture is possible when tumor are resected at the dome. Extraperitoneal bladder perforation can typically be managed with prolonged urethral catheter drainage. Intraperitoneal perforation is less likely to close spontaneously, usually require open or laparoscopic surgical repair. Management of hematuria. Management of hematuria during or after TURBT involve endoscopic hemostasis using monopolar bipolar loops to achieve hemostasis by pulgration of visible vessels, continuous bladder irrigation, or clot evacuation. Management of refractory hematuria. For persistent hematuria that does not respond to repeat endoscopic management, advanced options are considered, like alum irrigation with 1% aluminum sulfate solution for 24 to 72 hours. Formalin installation. This is an effective but more toxic option due to the risk of bladder fibrosis and potential renal failure. Arterial embolization to be done by intervention radiologist to embolize internal iliac artery to block blood supply. And palliative urinary diversion or cystectomy considered as last resort in the life-threatening hemorrhage.